Good morning, good morning. My name is Rubens Belford. I come all the way from Brazil to be here with you guys today. I have Professor Sitoros here with me.
Hello.
And we have 16 papers to be presented, so we'll try to be on time. I would like to invite Dr. Purnima Hajkarnikar Shapit. I hope I... Thank you. मेरी हिंदी बहुत अच्छी नहीं है, but I know, I'm working hard. Welcome.
Excellent.
Good morning, everyone. Thank you for your kind introduction. I'm so happy to be here. I'll be talking on a cross-comparative analysis of anterior segment OCT diagnosis versus histopathological diagnosis for ocular surface tumor in a tertiary care center in Nepal. The study was funded by a Cure Blindness project. We all know that OSSN is the most common non-pigmented ocular surface tumor. In a study done at our institute, it was found to be a second most common in 32% of all the orbitoocular malignancies, second only to retinoblastoma. It clinically presents as a unilateral vascularized mass which can be gelatinous, leukoplakic, papillary, or nodulo-ulcerative. And the diagnosis is made mainly clinically, and histopathological evaluation following an incision or excisional biopsy is a gold standard for diagnosis of OSSN. On top of this, anterior segment OCT also helps substantially in its diagnosis. It provides an optical biopsy and accurate diagnosis without the need of surgery. It is an excellent tool for monitoring of benign lesions and diagnosis and evaluation of malignant lesion, as well as follow-up for the recurrences. So we did a study. The objective of this study is to see the applicability and translatability of this imaging modality for ocular surface lesions. It is a prospective cross-comparative one-year study done at Tilganga Institute in Nepal. All the consecutive cases who were suspected of having ocular surface tumors and undergoing surgical excision were included in the study. After seeing the demographic data, clinical examination, and anterior segment photographic documentation, a high-resolution anterior segment OCT using Zeiss Series 6000 were acquired for all the patients enrolled. All the patients underwent a surgical excision of tumor and specimens sent for histopathological examination. The primary clinical diagnosis denoting anti-AIOS features were compared with the final histopathology diagnosis. So in the results, we had 77 patients with 53% females and 47% males, with the median age of 54 years, ranging from 18 to 87 years old. The bilateral disease was present in 3 patients, and they were all the patients of xeroderma pigmentosum. Conjunctiva only was involved in 30%, cornea only in 13%, and both were involved in 58%. Nasal bulbar conjunctiva was the commonest site involved in 51%. Based on the clinical assessment and ASOCT features, 84%, that is 67 eyes, were diagnosed to have OSSN, and rest of the diagnosis made were conjunctival nevus in 7, pterygium in 1, lymphoma, rhinosporidiosis, flected in 1 each, and conjunctival melanoma in 2. So in the anterior segment OCT features for OSSN, we took 3 features. That was abrupt transition from normal epithelium to the abnormal epithelium, the hyperreflectivity on abrupt transition, and the thickening of the epithelium. So this was another case of our study where there was a thickening of the epithelium and abrupt transition is there, but you can also see a cystic spaces. Normally these cystic spaces are present in benign lesions like nevus, but these are also seen in OSSN cases. This is another picture from the study where there is abrupt transition and thickening of the epithelium, but the hyperreflectivity is not uniform in all the cases, and the histopathology was found to be CIN2. Hence, the ASOCT features were not consistent in all the cases, and we found that hyperreflective epithelium was most consistent and most commonly seen in 85% of our cases, followed by thickened epithelium in 73% of the cases, and abrupt transition in 60% of the cases. So on histopathology, 69 cases were diagnosed to have OSSN of various grades, proving that clinical diagnosis using ASOCT imaging has sensitivity of 91%. In the histopathology diagnosis of also, when we go into the details, we found that CIN2 was the most common pathology in 33%, followed by CIN1, then CIN3 and squamous cell carcinoma in 11%, nevus in 3%, and rest are tabulated here. So this is a clinical one study, patient with clinically appearing like a gelatinous mass encroaching into the cornea and the cornea, and then it was in the OCT also we found thickening, abrupt transition, and hyperreflectivity, and on histopathology came out to be CIN3. Another case also looks like a gelatinous mass, but the hyperreflectivity was not there and thickening is there, and histopathology was found to be a granulomatous inflammation. Hence, on histopathology, 79% was diagnosed as OSSN on various grades. Among them, 63 eyes had HPE diagnosis matching with the clinical diagnosis assisted by ASOCT. Hence, the clinical diagnosis using ASOCT imaging has sensitivity of 91%. So these are some of our cases from the study. So I'd like to conclude that the study demonstrates the sensitivity of OSSN using ASOCT approach that reported in previous literature. However, there was a notable discrepancy in the uniform presence of classical OCT features, and these are likely to result from variation in the device, imaging protocols, and also a learning curve which we have recently acquired in our center. As ASOCT provides the optical biopsy, the need for surgery for diagnosis only may be reduced, especially when one is planning for a chemoreduction of the tumor, as well as monitoring of the postoperative cases of OSSN. And it is also useful for monitoring benign lesion of the ocular surface like nevus, pincula, or dermoid, where we opt to not to operate on these cases. These are my references. Thank you for your kind attention.
Very good, thank you.
Okay. So the next is Dr. Mary Elaine Diaz. I hope I'll spell it correctly. And will present the clinical profile and outcomes of ocular surface squamous neoplasia at the Philippine General Hospital. Dr. Diaz, please.
Okay, if she's not here, we can...
Okay. Dr. Diaz, you're not here. Okay, can we proceed to the next? Yeah, we skip it, and then we goes to Dr. Aldois Tariq with the presentation entitled Results of Intralesional Sclerotherapy for Treatment of Orbital Lymphangiomas.
It's very early Sunday morning. Come on, Brazilians are still sleeping, so I would not expect something different. We can skip that as well, and hopefully we'll have someone here. I see 3 people, so we're good.
Oh, okay, the next. Dr. Ayusha Rawat, are you there? Good. So, your presentation entitled To Collate the Efficacy and Safety of Interferon Alpha 2B and Surgical Excision in Management of OSSN.
Good morning, everyone. Today I'm here to present my paper on the comparison of ocular surface squamous neoplasia between medical therapy, that is interferon alpha 2B, and surgical excision, which is done in the tertiary care hospital. As we all know, OSSN is a broad term encompassing conjunctival intraepithelial neoplastic lesions. It is an elevated conjunctival lesion seen at near the limbus. It's grayish white in color with a tuft of blood vessels. Patients present with redness, irritation, and foreign body sensation. It is associated with ultraviolet B-induced DNA damage, P53 tumor suppressor gene, and impaired DNA repair mechanisms. Our aim was to compare the medical and surgical treatment plans for the patient. Objective was to evaluate the outcomes, to identify the characteristics associated with successful OSSN treatment and with recurrence, to describe the adverse events associated with both the treatment plan. It was a prospective interventional study conducted over a span of 1 year. Protocol included two groups. 10 patients received topical interferon alpha 2b, which was given in a dose of QID, 1 million international unit per ml, and 10 patients with lesion less than 4 clock hours and less than 5 were undergone surgical excision, and the patients were followed up at first, third, sixth, and ninth month. Inclusion criteria: more than 18 years and confirmed cases of OSSN on histopath. Exclusion: less than 18 years, patients with pterygium, with severe dry eye, pregnant or breastfeeding females, previous surgery or topical chemotherapy in the presenting eye, and invasion of adjacent structures like lacrimal punctum, plica, caruncle, or intraocular compartments were not taken. Coming on to the observation, we have divided the two groups, medical and surgical group. And what we have seen in the medical group, at first 3 months, there was a partial response in the patient. But coming from at 6 months, there was a response, complete response in eight patients. And following 9 months, there was complete response in 8 of the patient, 1 with partial and 1 with recurrent patient at 9 months. And onto the surgical group, at first one, we have seen there was free margins. No positive margin was seen after the surgical excision, which was done with the Shields technique, that is a no-touch technique. And but by the 9th one, what we have seen, that 1 patient had a recurrence. Post-operative outcome, this figure shows the surgical excision of OSSN. This was a female with mucoepidermoid cancer who underwent surgical excision, presented with positive margins at 9th month. And this was a partial response of topical interferon alpha 2b, which was seen at the 1st month. Leukoplaque OSSN, which was managed with surgical excision, with conjunctival suturing, as the defect was small, with free margins at 3rd month. And this was the other patient who has undergone surgical excision, which eventually developed limbal stem cell deficiency. Coming on to the discussion, medical group, no patient had full response at 1 or 3 months, but 90% did by 6 months, and 10% with partial and 10% with recurrence. And recurrence was seen in 60-year-old male patient with papillomatous tumor involving more than 6 clock hours, and who underwent surgical excision, and it was found to be squamous cell carcinoma. Previous studies, according to the Galore et al., Shetel et al., and Bohem, showed a median duration of 2.3 months for the disappearance of the lesions, and a median total treatment duration of 4 months. The recurrent rates of the ocular surface squamous neoplasia treated with topical interferon are between 0 and 17% in the recent literature. At 1 month, 100% of the patient had clear margins. After 9 months, 90% of the patients had clear margin, 10% with 1 impacted margin. The patient with recurrence was further managed with surgical excision with amniotic membrane grafting. Although successful topical chemotherapies may lessen the need for surgical care of OSSN, surgery remains a viable option for many patients. Surgery is a quicker and a more effective option for OSSN compared to a medical treatment. However, the use of additional treatments such as cryotherapy, chemotherapy reduces the risk of recurrence. Coming on to the conclusion, there was no significant differences in the demographic parameters, risk factors of the tumor between the two groups as determined by the statistical analysis. Both treatment techniques showed comparable efficacy in terms of clinical outcomes and recurrence rate. Our limitation of the study was it was a small sample size of 20 participants, which may limit the applicability of the results to a broader population. And in addition, the short duration of the follow-up period may have resulted in overlooking the long-term effects and relapse rates. Thank you.
Very good. Maybe the questions, maybe they will show up, right? That's the problem.
Yeah.
Bahutacha, thank you. We were thinking about doing questions, but the presenters that are missing might still come, so maybe we should move along and save questions to the end, if that's okay with you guys. Thank you. Very good. So I would like to invite Dr. Ratima Chokchaitanasin.
Okay.
Welcome. And she's going to present on visual prognosis in retinoblastoma patients with multimodality treatments coming from Thailand.
Good morning, all speakers and all audience. I would like to talk about the visual prognosis in retinoblastoma patients with multimodality treatments, and I have no financial to disclose. As we already know, retinoblastoma is the most common primary intraocular malignancy in children. The goal of treatment now, we move from self-light and growth to self-visions. And the objective of our study is aimed to evaluate factors associated with growth preservation and long-term visual outcomes according to clinical characteristics and treatment modalities. And this is a single-center retrospective review that we enroll patients between January 2007 and 2020 from Ramathipati Hospital, Bangkok, Thailand. This is the flow inclusions. After we exclude extraocular attention, we have 124 eye from 86 patients in our studies. 67 eye can preserve eye growth. And we have to exclude one eye with worse vision from bilateral groups to eliminate individual bias. And finally, we had 56 eye were analyzed in visual outcomes. For the data collections, we focus on baseline characteristics such as demographic data, classification, anatomical involvement, and treatment modality. This is our results. Our study found that our patients were slightly male predominant and 58% were bilaterals. The median age of onset of bilateral disease was younger than unilateral disease, and 3/4 of our patients were classified as ICRB and IIRC group D2E and HSCC stage 2B or more. Concurrent retinal detachment was found to be the most prevalent pathology in our study. And systemic chemo remains the mainstay of our treatment, accounting for 86%. IAC as primary and secondary treatments was used in 53 eyes, and 57 eyes was inoculated. For the final visual outcome, we found that 50% has good visual acuity. We used logistic ligation to analyze the vector associated with growth removal, and we found that all at once staging, including ICRB and IIRC group D2E and HSCC stage 2A or more, is an independent factor associated with growth removal. For the factors associated to visual outcomes, all stagings, macular stages, retinal detachment, and bilateral disease were found to be significant on univariate analysis. Only IIRC does provide a higher correlation to visual outcomes and better area under the curve that we only recruit in multivariate analysis. And after that, IIRC state A to C is an independent factor associated with good visual outcome, and macular involvement is an independent factor associated with worse visual outcome despite successful treatment. We focus on subgroup analysis of chemotherapy, and we found only systemic chemo provides statistical significance associated to growth preservation and preventing a worse visual outcome for ICRB and IRC group A to C and HSCC stage 1A to 1B. In conclusions, advanced tumors are the independent factors associated with growth removal. ICRB and IIRC group A to C and HSCC stage 1 were associated with good VA. The IIRC classification remarkably predicts the visual outcome compared to others. Eyes without macular tumor and retinal detachment were associated with good VA, and systemic chemotherapy remains the crucial treatment demonstrating the protective factor for growth removal and preventing a worse visual outcome for ICRB and IRC group A to C and HSCC stage 1A to 1B. And now I would like to talk about this. Our research is now available in AJO International Journal. If you want more information, please just scan QR code here. And I would like to say thank you, my mentor, Dr. Dongnet Rojaraporn, for helping me every step of publication, and thank you for your attention.
Yes, we are informed that Dr. Sheikh, the next speaker, Dr. Kadir, will not be able to come, but he will be represented by Dr. Mongre. Please, Dr. Mongre, you will have your presentation about lacrimal sac tumors.
प्रणाम। मैं तहे दिल से अपने मेहमानों का धन्यवाद करता हूं कि आप लोगों ने मुझे परमिशन दी इस पेपर को प्रेजेंट करने के लिए। I am Dr. Parveen Mongre. I am presenting this paper on behalf of Dr. Kadir, who could not get the visa to present this paper. I have no financial interest and conflict with this paper. The tumors of lacrimal drainage systems are rare, but they are potentially life-threatening. In one study by Dr. Shields et al., of 1,264 orbital tumors, only 2 were in the drainage system. And in another study of 1,705 eyes and adnexal tumors, only 2 were in the drainage system. They can be primary, secondary, or they can be mets. Of the 894 cases reported so far, 72% of them are malignant, and they most commonly present in the 5th decade of life. Epithelial comprises 71%, mesenchymal 12%, lymphoproliferative 11%, and melanocytic 4%. On reviewing the major case series, of all the cases, 75% are epithelial origin, and of them 72% are malignant, and of the total cases 72.5% are malignant. Epithelial, 26% are papilloma, benign papillomas, and most common malignant is squamous cell carcinoma, followed by non-keratinizing squamous cell and mucoepidermoid carcinoma. And of the non-epithelial variety, lymphomas and melanomas are the malignant tumors. They present most commonly with the epiphora and recurrent necrocystitis. They can also present associated with mass in the lacrimal sac area or bleeding from the punctum, ulceration over the masses, or bloody reflux with atraumatic irrigation. A firm, indistinct mass which is fixed to the underlying tissues with or without fistula, but with the blood discharge and tender on touch, is malignant. A comprehensive ophthalmic examination associated with syringing, probing, and appropriate imaging with CT scan or MRI and tissue diagnosis helps in proper diagnosing these cases. They mostly are contrast enhanced, mildly enhanced lesions. Stage 1 tumors are when there are signs and symptoms but no definite mass seen. Stage 2, a mass appearing but which is confined to sac. And stage 3, when this tumor extends beyond the lacrimal sac area to the adjacent orbital and paranasal sinus. And stage 4 is when it goes into the systemic metastasis. Depending on the tissue type, size, and extent, a complete removal of the tumor is the aim of the treatment. 40% of the time they are found on the routine DCR surgeries, so we need to modify our procedure every time. And along with the multimodality and multidisciplinary approach, these patients are managed and they need to be kept on virtually lifelong follow-up. Excision, complete excision is the treatment of choice, and in the cases, radiology and appropriate chemotherapy is also advocated. As I said, almost for 40% of time they are found on the routine DCR procedures. So these DCR procedures can be modified in the necrocystotomy at a later date or the same date with a complete tumor excision and with the excision of periosteum and nasolacrimal duct system. And in case of the stage 3 and 4, we need to do exentration, rhinotomies, PNS resection, or neck lymph node dissections also. Few cases here. First case presented early, 27 year in age, with the moderately enhancing lesion, came out to be a lymphoma. A word about the lacrimal sac lymphomas. Depending on the TNM staging, histological grading, they are amenable to surgery, radiotherapy, chemotherapy, or even immunotherapy. Case 2, again the mass, which is enhancing mass, came out to be solitary fibrous tumor. And this came out to be mucoepidermoid. He also presented in the 5th decade non-tender mass, which was mildly enhancing on the CT scan, mucoepidermoid carcinoma. Adenocarcinoma are the most fatal and the most common lacrimal drainage system tumors. A few case series studies on lacrimal tumors in the past 30 years, we see the epiphora and recurrent necrocystitis is the most common presentation. And in the benign type, epithelial benign time, it is the papilloma. And most common epithelial malignant is squamous cell carcinoma. And most common epithelial, non-epithelial is lymphoma and melanomas. We, reported 10 cases. In our case series, 30% were benign and 70% were malignant. And most common, 50% of our cases were hematolymphoid tumors, and 3 of them were marked. We saw recurrence in one of the case. When we see the prognosis, even the benign had a bad prognosis in the sense of virtually 50% of them recurs. Squamous cell carcinoma recurrence is 50% with a very high mortality, and non-keratinizing squamous cell carcinomas carries the worse prognosis. Hematolymphomas have a variable prognosis, but melanomas are often fatal. So to conclude, since the lacrimal drainage system carcinoma tumor masses are rare, so we need to have high degree of suspicion. Appropriate CT scan or MRI imaging need to be done. Early and appropriate workup with multimodality treatment. Careful inspection of the sac during DCI, DCR, and long-term follow-up is mandatory. Thank you very much. Thank you.
Thank you, Dr. Mongre. Thank you. I would like to call Dr. Yarovoy, presenting on brachytherapy with ruthenium or plaques for retinoblastoma long-term outcomes and analysis.
Good morning, dear colleagues. I'm going to present our results on brachytherapy. And 278 patients have been treated in our clinic with retinoblastoma, and 163 patients were treated using brachytherapy. There were multi-field and monofield brachytherapy, and 28% of patients had the only eye. Almost all of patients were pre-treated with all types of chemotherapy, and even 8 eyes were treated with EBRT. According to our knowledge, Russia is the only country where strontium plugs are in use, and recently we have published our results in Brachytherapy Journal. So we used ruthenium plugs in 71% of cases, strontium plugs in 21%, and both types in 8% of treated cases. There are very controversial data according ruthenium doses of brachytherapy for retinoblastoma from very high to very low. And there is no information at all about strontium radiation doses. So we used different doses for ruthenium and for strontium, and it was defined that optimal doses, apical dose for ruthenium is 89 gray, and for strontium radiation about 140. Numerous modes of brachytherapy were distinguished according to our experience. One field irradiation, the most often situation. Here are the examples of brachytherapy with ruthenium and strontium plugs. Multi-field irradiation from 2, 3, 4, and even 5 fields. Plaque transpositioning within one surgery. In some cases, 2 plaques simultaneously. Irradiation of multiple small tumors using rather small scleral doses without any damage to retina or choroid. Irradiation of vitreous preretinal seeds. And for precise irradiation of small tumors, we use custom-made plaque collimator. Comparing two groups of ruthenium and strontium radiation, it was shown that tumor control was equal in both groups, and there were much more complications in ruthenium group. So our eye retention rate about 91%, and 17 eyes were enucleated because of tumor progression or severe complications with loss of ophthalmoscopic control. There were relatively a big number of complications after ruthenium brachytherapy, proliferative and non-proliferative retinopathy, vitreous hemorrhages, cataract, and revealing the risk factors of complications. It was shown that the most important of them were tumor thickness over 2.5 millimeters, tumor diameter over 7.3, the larger size of ophthalmic plugs, scleral dose over 626 gray, time from intraarterial chemotherapy to brachytherapy less than 3 months, and posterior location of the tumors. So, in conclusion, it can be said that brachytherapy is still an essential part of retinoblastoma treatment. Strontium brachytherapy, along with its high effectiveness, has minimal number of complications, and the revealed risk factors of complications should be taken into account. Thank you.
No, not yet. The question would be at the end of the session. Okay, I think Dr. Yarovoy, you still stay
Okay.
at the podium because you will be talk on your next talk, long-term result of surgical excision of iridociliary tumors, please.
Thank you. So, about results of surgical excision of iridociliary tumors and implantation of artificial iris. Iridociliary tumors are very different in shape, size, location, histological origin, and surgical excision is still the main treatment option for such tumors, but it causes iris coloboma, cataract, that can decrease vision, cause aberrations, light scatterings, photophobia, and cosmetic defect. If small iris coloboma can be treated by suturing, a larger iris defect can be treated only with artificial iris implantation. But literature data about this technology was very limited. So we present our experience on 26 patients with iridociliary tumors treated within 20 years. 19 patients had tumors of iris and ciliary body, 6 patients with iris, ciliary body, and choroid, and 1 patient with iris tumor. So, according to tumor extension, we used different types of surgery. Iridocyclectomy in 19 cases, lamellar-sclerovectomy in 5, iridectomy in 1, and full-thickness eyeball resection also in 1. Histological results included uveal melanoma, and in 22 cases, and melanocytoma, adenocarcinoma, adenoma, and pigmented iris cyst. So after tumor excision, visual acuity decreased in all cases, and cataract occurred in 96% of cases with symptoms of photophobia, aberrations, and aesthetic disturbances. Within 1 to 111 months after surgery, artificial iris lens diaphragm were implanted, and there were different types of surgery according to capsule bag was intact or damaged. So after reconstructive surgery, within 13 to 243 months, visual acuity increased, photophobia disappeared, aberrations and disappeared, and cosmetic outcomes improved. There was only one recurrence without metastasis of tumors, and there were some complications. The most often was endothelial dystrophy, macular edema, and some others. So here is an example of a patient, 70-year-old patient with iridociliary melanoma, with the excision of tumor and subsequent implantation of artificial iris. And another case of 15-year-old patient with suspicion on iridociliary ciliary-choroidal melanoma with tumor spread within fine needle aspiration biopsy, scleral channel made elsewhere, and the surgery was fulfilled with excision of tumor, and 6 months after tumor excision, cataract was removed and optical reconstruction was fulfilled with implantation of iridociliary diaphragm, and the visual acuity is 1.0. Here are another cases of our patients with large tumors and large colobomas, and not bad results in cosmetic. So the conclusions are artificial iris or iris lens diaphragm implantation is an effective and safe procedure of managing the iris large-sized colobomas after excision of iridociliary tumors. And it can improve vision, cosmetic outcome without increasing the risk of tumor recurrences.
Very good.
Thank you very much.
Thank you, doctor. Thank you. If Dr. Diaz or Aldois arrive, please let us know. I'd like to invite Dr. Jarupanik. She's going to talk to us about evolution of intra-arterial chemotherapy and globe salvage outcome in retinoblastoma. Welcome.
Okay, good morning, everyone. My name is Nisha Jarupanit from Ramativity Hospital, Mahidol University. I'm pleased to present our study on the evolution of intraarterial chemotherapy and its impact on globe salvage outcome in retinoblastoma. I have no financial disclosure related to the presentation. IAC, first introduced in 1998 and refined over the years, has revolutionized retinoblastoma treatment. However, protocols vary globally, impacting the treatment success. Our study evaluates the outcomes of different IAC protocols used in our center. We conducted a retrospective review of intraocular retinoblastoma patients treated with IAC at Ramativity Hospital from January 2009 to June 2022. We divided patients into two groups based on treatment periods, techniques, and medications. We analyzed factors affecting globe salvage and visual outcomes, including patient demographics, tumor staging, procedural techniques, and additional treatments. We compare the baseline characteristics of retinoblastoma patients treated with IAC in two different time periods. Group 1, from 2009 to 2017, included 27 eyes from 26 patients, while Group 2, from 2018 to 2022, included 28 eyes from 26 patients. Patients in Group 2 were diagnosed at a younger age with mean age of 74.4 months compared to 122 months in Group 1. The male to female ratio was similar between groups. We observe a shift in laterality with more unilateral cases in group 2 compared to group 1. Regarding tumor staging, most cases in both group were advanced, classified as ICRBD or E. However, group 2 had a higher proportion of ICRBD cases and fewer ICRBE cases. This table outlines the IAC techniques used. We observe an evolution in IAC techniques. Group 2 utilized larger microcatheters and microguide wires. Group 2 also demonstrated a higher rate of successful cannulation session, 100% compared to Group 1. The use of super-selective techniques was also more frequent in Group 2 than in Group 1. Primary IAC was more common in Group 2 than in Group 1. There were significant differences in drug protocol between two groups. Group 1 predominantly used melphalan, while Group 2 shifted toward a triple drug regimen, including melphalan, topotecan, and carboplatin. Kaplan-Meier survival analysis showed significantly higher globe salvage probabilities in Group 2 compared to Group 1. This table shows the globe salvage rates. Overall, globe salvage rates improved significantly from 44.4% in Group 1 to 89.3% in Group 2. Notably, in Group 2, the globe salvage rate for ICIB Group C was 60%. It's important to mention that the enucleation in this group was due to the vitreous hemorrhage, not the tumor progression, and the pathological report confirmed the complete tumor regression. Visual outcomes were assessed in eyes with macula-sparing tumors with favorable outcomes observed in 2/3 of eyes in Group 1 and almost 60% in Group 2. From the multivariate analysis, ICRB Group D patients had a higher globe salvage rates compared to Group E in both time periods. Single drug therapy was associated with lower globe salvage rates than triple drug therapy. Extramacular tumor location and the absence of retinal detachment were associated with better visual outcomes. In conclusion, the evolution of IAC techniques and drug regimens significantly improved globe salvage in our center. Triple drug therapy proved most effective, especially in ICRBD cases. However, macular involvement and retinal detachment remain challenges for vision preservation. Okay, thank you for your attention.
Dr. Rolika Bansa, are you there? Okay, now it's time for you to present your presentation on melanoma by tumor size categorized based on the cancer TCGA classification.
Very good morning, everyone. Thank you for coming today, even though it's the last day in early morning. And I'll be talking on metastasis-free survival of uveal melanoma by tumor size category based on TCGA classification in 1001 cases. I thank my mentors for the opportunity to work and statistically analyze all these patients, and I'm grateful for them as well. So as we all know that uveal melanoma, like ocular melanoma specifically constitutes 5% of all melanomas, with uveal melanoma representing 85% of all ocular melanomas. And when we say 10-year melanoma-related metastasis, it actually ranges from 12 to 49%. We have seen this paper like for a long time, since 2009, and we know that every millimeter of increase in thickness adds to a 5% increment in the risk of metastasis. It's known that even based on size, the risk of metastasis increases. And it has been stated previously in the other papers as well, as you can see over here. And based on that, in 2017, we have analyzed that based on small, medium, and large thickness, we can see that the complete monosomy increases for the larger tumors. And this also kind of has been extrapolated in 2019, and we have stated that TCGA classification is basically related to the monosomy of chromosome 3. So we can say that TCGA C and D are the ones associated with monosomy 3. And we have also seen that the distant metastasis rate and the distance and the death rate also is higher with TCGA C and D. And this has already been proven in the past. Now, this also concludes that we can safely say that TCGA A and B are the ones with lower risk, and C and D are the ones with higher risk. So we have a categorization in mind that when the tumor size grows, the risk of metastasis increases, and TCGA A and B are low risk and C and D are high risk. So what we did was we analyzed with can tumor size category be used for metastasis-free survival at the time of presentation? Like, do we really have to go through genetic analysis? Because when you're talking about Asian Indian countries or developing countries, we don't have genetic analysis, and it's not cost effective. So what we tried to do was we went retrospective. So what we looked at was to estimate the metastasis-free survival on the basis of tumor size category in the classification of small, medium, and large. So we analyzed the study, and we went with the Kaplan-Meier free survival rates and assessed the MFS. So what we saw was that similar age and race distribution was seen with no difference between the sex and the affected eye in the patients. And we also saw that, specifically talking about small tumors, as you can see over here, low risk A and B and high risk C and D. Both of them have favorable survival when it comes to small tumors, irrespective of the TCGA. So that's good news, right? So we also saw that the 5-year metastasis-free survival is very high for all of these patients, low risk or high risk. When we move on, we went to the medium category. In the medium category, the worst prognosis was seen with higher risk TCGA groups. That means the 5-year and 10-year survival increased, the risk increased. And when we talk about the 5-year metastasis-free survival, it was lower for C and D, that is the higher risk category. Similarly, for the larger tumors, the numbers were further low, right? So it was worse prognosis with increasing in large melanoma. And the 5-year metastasis-free survival dropped further down, 40%, 23%. So these numbers are extremely important, because when the patient comes to you, they're going to ask you, how long will I live? What do you think? Do you think I'm going to get a metastasis? Everyone's scared. You need numbers to give them. So if we have to summarize between small, medium, and the large tumors, we can safely say, here are the take-home numbers, that when it is about the the low-risk categories, that is TCGA A and B, by tumor size, 86% at the time of presentation, small tumors will be low risk, right? Medium tumors at the time of presentation will be 60% low risk, and large tumors will be 58%. You can provide these numbers to your patients safely. And we can say that the 5-year survival rate in small tumors is 98%, very high. Medium tumors is 94%, very high. And large tumors is 86%. But when you talk about the 10-year survival rates, it drops in the larger tumors. It is 54%. So when we have to discuss, we can just say, tumor size category is also a very efficient prognostic indicator. TCGA is a prognostic indicator, and tumor size category is an indicator of TCGA, so we can safely use that. So we can say small melanomas, favorable, medium and large, worse prognosis, and these are the numbers. Take them safely, provide it to your patients, and at 10-year survival rate, the larger tumors drop down to 54%, and it can serve as a surrogate for the TCGA classification. So I thank my mentors and all our patients and our team. Thank you so much.
Thank you. Very nice.
So maybe invite Dr. Ferdi Iskandar, which will be talking on the efficacy and safety of bleomycin injection of the primary management of OVLM.
Not fair. He brought his team to applaud
Yeah.
him. I want the same next time.
Thank you.
I'm his team too.
Powerful team.
Yeah. Thank you for the opportunity, dear chairs and professors, doctors. Good morning. And this is my systematic review with my teachers. So I have no conflict of interest. So orbital funny lymphatic malformation, or OVLM, is an abnormal vascular channels lined by endothelial cells with venous and lymphatic component, and it represents 1 to 3% of all orbital masses. And an acute state of OVLM may cause a structural and functional impairments, as you can see at the picture on the right side. So it may cause disfigurement and discomfort, and it's a devastating condition for the patient. And for the epidemiology, Hawaii, it has 1.1 to 5.3% per 10,000 live births. And in our hospital, Cipto Mangunkusumo Hospital, it has 16 per 1,300, or about 1.2% from 2018 to 2022. And the primary management of OVLM includes observation, medication, surgery, and sclerotherapy. However, surgery tends to regrow with a recurrence rate of 71% after surgery. And so in this study, we have a picture of the sclerotherapy. And bleomycin has an FDA approval for chemotherapies of head and neck and others. However, it has no FDA-approved treatments using intralesional bleomycin, but used off-label for cutaneous and vascular tumors. So in this review, we will explore the efficacy and safety profile of bleomycin injection for OVLM with the proptosis reduction, recurrence rate, visual acuity improvement or stabilizations, and complications. So it is a systematic review with inclusion criteria, clinical trial, prospective cohort, retrospective cohort, case control, case series, and case report with the populations of patients with orbital phenollymphatic malformation, and the intervention is bleomycin injection, and no comparison with the outcome of proptosis reduction, recurrence rate, visual acuity, and bleomycin complications. With the exclusion is not available for full text, not written in English, and involvement of other treatments other than bleomycin injection. So we have 48 studies at the beginning, and then we exclude, and finally there is 10 studies in the review. So these are the 10 reviews, and for all the studies, study ranges from 2008 to 2018, with the median age of 18 years old and 131 eyes, and with the median follow-up of 6 months. So this is the pooled outcomes. First, from the proptosis degree, so about 88% of our 115 eyes had an improved proptosis degree, and only 1% or about 1 eye had recurrence, and for the visual acuity, 64% had improved visual acuity, and 36% stable. And for the complications, it only had minor complications, which is 47% skin hyperpigmentation, and only 27% inflammation, and mild proptosis aggravation, about 13%. So this is the pooled outcomes of the bleomycin injection therapy. So 87% the proptosis improved, and almost had no recurrence, only 1%, and the visual acuity improved about 63%, and the complications is only all mild. So bleomycin as a non-surgical treatment for OVLM now is considered as the first-line therapeutic outcomes because it has safer outcomes, and it has become the option among other sclerotherapy modalities because its safety profile, high success rate, affordability, and lower potential side effects by the mechanism of inhibiting the DNA synthesis, and has a sclerosing effect on vascular endothelial by inducing scarring and fibrosis. And in our studies, so we had 87% in overall reduction in proptosis. In other studies, 65 to 95%, and visual acuity 63%. In other study, 50 to 78%. And in our study, we only have minor complication. And however, the number of injections, it has no protocols, so it is still variable. And in our study, we have pooled median number of 2 injections. And for the injection interval and bleomycin dose, it is still varied. Our study had limitation because it has low quality studies, and visual acuity only reported in 1/3 of study populations, and no RCT compared bleomycin to current alternative treatments for OVLM. And there's heterogeneity in bleomycin injection methodology and reported results. So to conclude our study, bleomycin injection as a sclerotherapy is an effective and safe treatment modality for OVLM. The efficacy was seen mainly in proptosis reduction. And for the long-term OVLM follow-up, showed a low rate of lesion recurrence, and the improvement of stabilization of visual acuity can be seen after bleomycin injection and has low complication rate. And for the bleomycin injection can be given with the protocol of 0.5 unit per kilogram body weight, maximum volume of 4 to 5 milliliter per injection, and maximum cumulative dose of 5 unit per kilogram body weight. Thank you.
Thank you. Thank you very much. So we'll move on to Dr. Lee, presenting on epidemiology of ophthalmic cancers in... Is Dr. Lee around? Nope. Okay, so we'll skip Dr. Lee and we're going to Dr. Yarovaya. She'll be presenting on comparison of outcomes of gamma knife surgery, routine brachytherapy, and enucleation for uveal melanoma in comparable groups. Thank you.
Hello, dear friends. So we are going to present our results of comparison of outcomes of gamma knife radiosurgery, brachytherapy with ruthenium, and enucleation for uveal melanoma. So there are about 300 patients per year with uveal melanoma in our center, and 60% of them are treated with ruthenium brachytherapy. Surgical resection underwent 6% of patients, including transscleral resection and transvitreal resection, which is known also as endoresection. We also perform enucleation with implantation of endoprothesis in cases of large size, unfavorable location of uveal melanoma, and secondary changes also. And from the beginning of 212-year period, we use stereotactic radiosurgery of uveal melanoma for unsuitable tumors for other eye-sparing treatment as an alternative to enucleation. In total, there were 139 patients treated either with gamma knife or cyberknife radiosurgery. So among total of 99 patients treated with gamma knife radiosurgery, there were also male and female, but women were presented in most percent of cases. There were in much percent of cases big tumors because they were not adapted for another treatment. And we performed an attempt to compare the results of gamma knife radiosurgery with the enucleation by comparing metastasis-free survival, and with brachytherapy, comparing local control complications, eye retention, and metastasis-free survival also. There was a group of patients who underwent enucleation in number of 190, and it also was compared to the group of patients treated with gamma knife radiosurgery. So these two groups were statistically comparable, and there was no difference seen in patient survival during the follow-up period, which is comparable to the very limited publications that also show us that radiosurgery enucleation did not influence metastasis-free survival. Going to the to compare of brachytherapy, there was a group of patients treated with brachytherapy, number of 346 patients. They were also standardized. They were also comparable. These two groups were comparable by the main clinical features, including tumor thickness, tumor diameter, retinal detachment, ciliary body involvement, juxtapapillary location, and also follow-up period. Local control was achieved in a similar percent of cases during the brachytherapy or gamma knife radiosurgery. There was no significant difference. And also the regression rate was pretty the same during the gamma knife radiosurgery and also the brachy. So the total amount of complications is pretty the same in both groups, but if you can see in the table, the number of retinopathy is much more numerous in group of gamma knife radiosurgery. But some of these complications can be treated with, for example, intravitreal injection of anti-VEGF or intravitreal dexamethasone. So these complications are comparable to the literature data, and it also depends on the dose that is prescribed. Vision outcomes were pretty the same in both groups and had no statistical differences. Eye retention in our group of gamma knife radiosurgery with 95%. During the 5-year rate, it was 88%. And also in groups of gamma knife radiosurgery and brachytherapy, there was no any difference in eye preservation. And also the main factor we should analyze is metastasis-free survival. There was no difference also between the patients treated with brachytherapy and gamma knife. And there are very little number of publications that demonstrates the same results, but they are pretty the same that we have achieved. And in conclusion, we'd like to say that single fraction gamma knife radiosurgery is a reasonable salvage modality for uveal melanoma, unsuitable for rutinary brachytherapy or resection without increasing the risk of metastasis. Thank you.
Dr. Varovaya, would you please remaining stay there because you have the next talk of you on the title of residual retinoblastoma after chemotherapy, when to treat or not to treat.
So the next topic I'd like to speak about the residual retinoblastoma. It is known that there are 4 types of regression of retinoblastoma, and how should I go to at the beginning? Okay, I'll do it myself, thank you. So it is known that the third and the second type of regression has characteristic of incomplete tumor regression when you can see the residual tumor. So there is a question, should we treat it or not? Because according to the data, some viable tumor cells can be detected, but when you treat these tumor lesions, you also can reach the complications. So to treat or not to treat is the main question we should talk about. So indications for the treatment are active tumor, neovascularization, own vascular network, and also the tumor growth. Indications for the observation of the residual retinoblastoma are translucent tumor tissue, no vessels seen during the examination, and also no tumor growth within the long period of follow-up. So among the 545 patients with retinoblastoma, there were 193 patients that had incomplete tumor regression in our center. 142 eyes were treated, and 18 patients, 84 eyes were not treated, they were observed. So the aim and the purpose of our study was to evaluate the safety of dynamic follow-up of patients with incomplete regression of retinoblastoma, and based on statistical analysis to determine predictors of continued tumor growth. Among 80 patients, there were 58% of boys, and there were also binocular and monocular retinoblastomas with different tumor size. The groups of retinoblastoma eyes are presented here, and there were 32% of 2 types regression retinoblastomas and 68% of 3 type regression retinoblastoma. So in 76% there was no tumor growth seen. In 21% there was a stabilization, and in 55% of patients we also seen following tumor regression. And in 24% of patients, tumor growth was observed during the follow-up period. Additional treatment was needed in all cases. Treatment complications among these 24% of patients were observed in 5 children, including radiation retinopathy and so on, and in some cases, in 4% of cases, enucleation was needed because of complications or tumor growth. So going to the statistical analysis, we analyzed such criteria like predictors of tumor growth. And as you can see on the slide, the regression type is a significant statistically significant criteria. So we also analyzed the dependence of growth on the type of regression. And as you can see on the slide, the second type of the retinoblastoma regression is more preferable, is a type of regression of low risk. And we also analyzed the type of growth. And as you can see on the slide, the most frequent time for tumor growth is the period under the 2 years of follow-up. So in conclusion, we'd like to say that observation is a possible management tactic for patients with chemo-resistant retinoblastoma, and in some cases an alternative approach in the case of tumor localization in the central parts of the fundus on a single or only side-seeing eye. Tumors of two-type regression significantly tend to continue to grow in a smaller percentage of cases, which is important to keep in mind when deciding whether additional local treatment of a residual tumor is necessary. Tumor growth most often occurs in the first 2 years, which must be taken into account when planning follow-up examinations in this category of patients. And if tumor growth is detected, local treatment can save 96% of eyes, while complications develop in no more than 23% of patients, and as a rule, they are completely curable. Thank you.
Okay, so would like to invite Professor Liu. Professor Hui Liu.
Not here?
Dr. Shauhan. Okay, so I guess we do have a few minutes.
Yeah.
If anyone would like to make question or comment, please step to the microphone. Just try if it's on.
Yeah, Dr. Vera. So what do you prefer? You said results in cyberknife or gamma knife, enucleation, brachytherapy, it's all almost the same results. So how do you decide what to do and when to do?
So in every case when we can save eye, it's better to save eye, because we have pretty the same results when we speak about the survival rates. So if we cannot enucleate, we should not do it. So I think that this is the reason of our talk.
You don't have the results with cyberknife?
Yeah,
KUKA
we do
robot.
perform cyberknife also as a gamma knife, but this is a new group, and we are just try to follow up these patients. And at a glance, there are no differences between the cyberknife and gamma knife radiosurgery.
It's a KUKA robot. You see, it's a more precise, frameless, bloodless cyberknife. You know that, I suppose.
That, but in
because we have been using it, and the results are too good.
In cyberknife procedure, we don't need the frame.
Yeah, that's what I said, the frameless.
It's a reason for patient, but in the result, when we manage the eye, there is no difference between two procedures.
I think what she refers to say is that even though the type of radiation does not, even if the results are the same, I think the location of the tumor or in the site of the tumor kind of matters as to the choice that you make about which type of radiation you would like to use. Okay, so I had a few questions, if I may ask. Is that okay? All right. So my first one was to Dr. Nicha, right? So why were there two groups that you had divided? I know that Dr. Rajanapan's first paper has been the first group, and the second group is the current group. But what was the exact division between the two groups? It was just the duration, or was there a reason for the division in the two groups? You had the two groups divided by the year, right? So was there any difference in the treatment modalities or something like, why were there two groups that were divided?
We changed our technique and we changed our treatment protocol. That's why we divided them into two groups. Before we used only one medication, melphalan, and the second part we used 3 drugs, and we modified our cannulation technique.
Okay.
Yeah.
So would you say that you would say that triple drug, you would prefer single drug over triple drug? That's what the essence of it was.
The latest one, the
Mhm.
latest group, we use 3 drugs, and we
Right.
find that our result is better.
Better with the triple
Comparing
drug.
to, yes, better with the triple drugs.
Right. And that would be single would be melphalan that you were using.
Yes,
So less of RPE mottling as well.
and
Less would be the RPE, retinal pigment epithelium
Yeah.
mottling, because of the side effects of.
in both groups, we found no difference in
Okay.
terms of the ophthalmic complications.
Complications.
Mhm.
Right.
But
Okay.
the efficacy is higher.
Yes,
Okay.
I agree with you because using 3 combination would risk with high the risk of
Yeah.
retina toxicity, especially with melphalan. But you didn't find that in your study,
Both groups we use melphalan.
okay?
And with melphalan alone and melphalan plus topotecan and carboplatin, we did not find any difference in terms of the ophthalmic complications. But in terms of efficacy, it's
Better.
more efficacy
In a
in
triple
the
group.
triple drug.
Triple
Right.
drug.
Yes.
Okay.
Actually, I agree with those findings. We had a study on 163 eyes where we have also noticed that because we are kind of reducing the dose of melphalan now, because in single drug it's higher, triple drug it's lower, and the 2 other drugs are complementing. So our complications were actually lesser than the single drug cohort, because now you have 2 drugs helping melphalan. So we saw amazing results with triple drug. We advocate for that.
Okay,
Absolutely.
thank you. It'll
Thank
be
you.
interesting to discuss about it later on.
Yeah.
Yeah?
Yeah,
So, still
do we have time?
We have a couple more minutes. Okay, couple
May,
more
may I
minutes.
ask Dr. Vera? In case of retinoblastoma, you said that you do the careful observation. How is your observation protocol? And do you have any clues that which signs of the tumor that will grow and wish that we can extend the follow-up? Do you have any clues or clinical?
Usually when we stop our treatment, we welcome our patients every 1 month to the red count and to their observation. And then when everything is stable, the period is longer and longer and longer. But usually in the first year, even if the child or eye is stable, we used to manage them every three months, the first year. And then we go to 4 months, and then when the child is stable for 3 years, we go to the 6 months period follow-up.
Actually, in observation, the regimen that we follow is 6 weekly for 3 times, then 8 weekly for 3 times, then 3 monthly for 3 times, 4 monthly for 3 times, and then we move to 6 monthly 2 times, and then we go yearly. So that's what the regimen that we follow, if that helps in
Only 2
observation.
years is maximum, no? You need.
Huh?
2
Sorry?
years is maximum
No.
for the growth to take place.
No, when we see the patient stable within 3 years, then we go to their observation every 6 months.
Right.
Yeah,
But
yeah,
we still observe.
Yeah.
Yeah.
Dr. Farah.
And I would like to say that I think that this protocol that you say, regular protocol, is not equal for each patient.
No.
Because
varies.
you have to choose, because when you have a calcium or flat scar, there is no reason to welcome patient
Yeah.
and to see patient every 3 weeks.
Exactly, it depends a lot on the type of regression that
sure.
you have. Like if it's a
Sure.
flat scar, we would go for like 6 monthly or
Yes, it's
3
pretty the
monthly,
same.
and then
Yes.
but we don't do anything less than 3 months. We start with 3 months, then 4, then 6, and then yearly.
I see.
Okay, very interesting. Okay. Did you check for the age of the patient for the risk of the eye group? The age of patient.
patient in what group? In gamma knife or
Oh.
retinoblastoma?
Retinoblastoma.
The age? From 2 weeks, just.
Okay, I'm asking you regarding the residual retinoblastoma treat or non-treatment. This is the other topic.
I think that age does not have any influence of the treatment.
Okay.
So residual retinoblastoma you can see in 2 weeks or in 3 years, it doesn't matter.
Yeah, in my observation, the younger the tumor, the younger the age, and then the more aggressive the tumor growth.
Yes. Actually, there's a paper that has been written on the same, that age does matter in terms of recurrence. They
In
have
recurrences, sure. And usually we see recurrences in the not upper, but the yes.
Yes,
side.
in germline, yeah.
Okay.
Yeah, Dr. Andrew, the material used for iris, artificial eye,
Please.
material used for making of your artificial eye,
What material
iris.
Oh, what material? Acrylic. Acrylic. Hydrophobic acrylic lens.
You have the surgery.
Not myself, but my colleague.
Okay.
I am an oncology. And a small comment concerning the recommended period of follow-up. It also depends on type of treatment. For example, after laser thermotherapy, recommend a month or month and a half. And after brachytherapy, the first observation we recommend in 2 months or even 3. Because the risk of incomplete effect after thermotherapy is higher than after brachytherapy.
Yeah, but the acrylic is heavier than the silicone, I suppose, no? And it is stiff also.
Silicone?
You said the material used is acrylic, no?
Yes. Acrylic.
Yeah. So it's stiffer than silicone, that is what I mean to
Yes,
say.
yes. It's different.
Thank you.
Okay.
Ruben?
Maybe I didn't catch.
Can I last question? I think we have 10 minutes, but
Yeah.
sure, just last question, just out of curiosity.
Yeah, short question, please.
Right, very short. So, Dr. Andrew, you had mentioned that the plaque dosage that you had preferred was 88 gray in your study.
Yes.
Is that right? So I think the papers that you had showed in which the 88 gray was used, that was small plaques with the dose titration, titrated dose of 88 gray. But for RB, we prefer to use 45 gray of radiation.
Sure. There are numerous publications, a few publications concerning lower doses. And even recently with ruthenium. And in all these publications with low doses, the level of regression low and the level of recurrences high.
Okay.
Look at these publications and you will see that. So we also tried to use 50, 60 gray, and we revealed that there are a large number of incomplete regressions and recurrences.
And you never saw tumor necrosis or vitreous hemorrhage in your cases?
No.
Okay.
No.
Interesting.
It's ruthenium, not iodine.
Yeah, ruthenium.
Okay, thank you.
Can I?
You still have, yeah?
Can I ask one question to Dr.
Yes, please.
Andrew again? You showed that on retinoblastoma with 2 large tumors, the double plaques, the simultaneously double plaques. So instead of that, the usual practice is that instead of using 2 plaques simultaneously and increasing the dose of the radiation and the risk of the retinopathy, why don't you just give systemic chemotherapy, chemoreduction, and then TTT, which gives lesser complications?
Sure, you're absolutely right. But these these children were heavily pretreated with all types of and systemic and intraarterial chemotherapy, and that was the only eye. And the tumor in the shown case was too large for thermotherapy.
Or systemic?
No, for thermotherapy, for laser. Too large for laser.
Yeah, so why not like give the systemic chemo reduction and followed by?
Yes, of course, but chemo reduction was unsuccessful in those cases. Of course, the first choice is chemotherapy.
And I also have questions for Dr.
Sure.
Andre. Sorry. I saw some cases that you put a plaque in retinoblastoma, and the tumor is like 2 millimeters thickness. Why would you choose the plaque brachytherapy over the local treatment?
Plaque over
Over
local.
local treatment like TTT or
yeah.
cryo.
Of course, we prefer TTT, but some cases and white funders do not allow to use TTT effectively. And we have very many cases of TTT, over about 500, and we feel the case that is suitable or not for laser.
Have you tried the ICG-induced TTT?
ICG?
ICG-induced TTT.
You know, when there was the first publication of ICG improvement by Jasmine Francis from Abramson Group, we tried to use it, but we did not find any improvement. So we do not use now it.
Thank you.
Very good. Any more questions? Was your final question? Very good. So I'd like to thank all of you for coming. Great presentations. And hopefully we'll see you guys in Brazil. Don't forget to bring your bulletproof vests to Rio.
What?
Yeah, I'm just joking. Thank you very much.
Okay. May I invite all the speakers to come forward for taking a photo? Thank you.